right. Well, we are back to talk about data and equity. And I must say, I'm really excited about this panel because all day we've been talking about how to establish a data team. We've been talking about buzzwords and governance and public-private partnerships. And now what we're ending with is how we can put data into action to actually address some of the challenges we've seen, especially most recently highlighted with some of the social change. And we have two fantastic experts that are going to help walk us through kind of how they've experienced data and how they use it in their day-to-day. And we have our first panelist is Dr. Demetre Daskalakis, and he is the director of the Division of HIV and AIDS Prevention with the National Center for HIV and AIDS and at the CDC. And we also have Nick Lucius, who is the Chief Data Officer for the City of Chicago in the Office of the Mayor. And we are extremely excited to hear from them and have them share their experiences. So gentlemen, thank you for joining us today.
Thank you, Patrice.
Thanks for having us.
All right, so want to just set a little bit of a foundation, and I'm going to ask you both the same question, and I'll start with Nick. What drew you to your current role, and when did you first recognize the power of data?
What a great question. So thanks for having me. This is really exciting to get to talk to some like-minded folks for a little while, a nice break from my regular day. And you know, it's a long answer. I'm going to try to keep it short. I didn't start off working in data or even a science math type field. I was a lawyer for about 8 years or so. And in my practice, I worked as a municipal lawyer. I needed to get data from government agencies in order to understand my cases and take my evidence to court. And so that was the beginning for me of using information that city agencies in the city of Chicago use for their operations, and having to get insights out of it, access it, put together different reports and analytics in order to do my job. And I really enjoyed that aspect of the job. And I also saw what a huge challenge and opportunity there was in a government setting like this and using data. And so eventually I moved over to working on data full time. I always had a background in computer science, so it wasn't a complete out of the blue movement for me. But to move into data full time, I naturally ended up working as a data scientist for the city of Chicago. And I say naturally because that was my home base of the data I understood. I knew how the city did its work, and I knew where the data was, and it made a really nice transition. And then last year, at the beginning of the year, Mayor Lightfoot appointed me as City of Chicago's Chief Data Officer, and just in time to get really busy with data last year over the course of the pandemic. And so that's just a little bit about how I got introduced to data and started working in this role.
Thank you, Nick. So Dr. Daskalakis.
So that's my turn now. So I am an infectious disease doctor. And since the very dawn of the beginning of my medical career, all I've ever really wanted to do is HIV related work. That there were several distractions along the road, including my work as the division director for all infectious diseases in New York City at the Department of Health that included STIs and sexually transmitted infections, tuberculosis, and measles in 2019, which was a major outbreak for us, and COVID-19, which was our major outbreak of 2020. So the power of data for me really began as a physician, where you were able to see that the more data you had and the easier you could access data on the folks that you cared for, the more appropriately you could care for them. plan. Then when I transitioned from doing individual patient care to public health, it became really apparent that your organism size changes from an individual to a population. And what you learn is that having data that is able to describe the experience of a population, especially with a specific disease state, ends up being critical to be able to make program and research work well together to achieve the ultimate goal of improving people's health. And so HIV specifically lives in a very sort of special place from the perspective of data, both from the protections perspective. It is some of the most protected public health data, though all public health data is protected. This one has even more levels of protection, which creates some challenges, but also some opportunities. It also has a high level of completeness, which is a lot different than other data, including some of the data that we've seen with COVID-19, specifically around race, ethnicity, and other sort of areas that we delve into from the perspective of equity. So I'll use that HIV hat for a moment to say that we really use HIV data to be able to better identify strategies for interventions. And I will give you a great example of how we realize the power of the data. And it's the Ending the HIV Epidemic initiative in the United States right now. And this initiative really looked to identify parts of the country that had the highest prevalence and incidence of HIV, and then do an equity intervention, which is to add funding to them, specifically because of the fact that we were able to measure what was happening on the ground, and that there appeared to be more of an issue in certain jurisdictions more than others. So in the first round of this, we were able to fund 37 states, 57 jurisdictions total. So some states have multiple counties in them. But ultimately, the goal of that is to accelerate the decline of HIV in those jurisdictions overrepresented in the epidemic. With that said, HIV also has the ability to do some really amazing things with the data and shows the power of data, where we're able to do things called data to care and cluster and response detection, where we're able to with our jurisdictions, identify people who are out of care and deploy specific resources to them to see if we can convince them to come back into care. So HIV, I think, is an example of one infectious disease that has a high level of data, high fidelity data from the perspective of what happens on the ground, and also data to action, going from an observation to intervention. So that was my long-winded answer, which I don't think was as good as Nick's, but that's my experience.
Well, what's interesting is that we're seeing kind of the more locally focused view, and then the broader national view, which I think is really important to understand, that there's like a through line, but then there's also a difference in approach. And so what I'm curious about now is, how do you take that local approach and apply it more broadly? And it could even be within a city. So if you're looking at a neighborhood within a city, or you're looking at a city and then the country, how do you take something that's so local, apply it more broadly, and make sure that we're still having the impact that's necessary? And this is for both of you, actually. Start with Nick.
All right, so I think it's a fantastic question. It's something that we think about regularly, and I'd say that if there's one of the biggest strategy the way we have around that is public dissemination of our findings and our information, because when a federal agency or any kind of like national group of people that are looking to do analysis and find out how do these local trends kind of boil up to the national level, you need to have accessible data, data that you can find, data that's public, and kind of remove some of the administrative burdens around having to go to 50 state jurisdictions or hundreds of municipal jurisdictions in order to create those data connections and get all the information. So our open data program is the prime example of how we kind of think about our relevance as the third largest city in the country, and know that the problems that we have locally really do inform problems and solutions that we have locally really do inform the national picture. And so we make a concerted effort to make our data automated, coming out of our source systems and going out to the public, and that we continually add data. I think we have over 700 million rows of data on all sorts of things, from crimes to building permits to the temperature in our lake, at our beaches, just all kinds of different data points that are just always being updated and always being put out there for whatever uses there are. We can't even contemplate all the different uses, and we're always just amazed and surprised by what we see. Just recently, there's been a lot of use of our ride-hail data. We collect data from Lyft, from Uber, from other ride-hail companies, down to the trip level of where the trip started and where the trip ended, and we post every one of those rides. It's well over 100 million rows of data just there, that data is used to inform studies on equity, studies on access to transportation, and studies on cost of transportation, and driver shortages, and just how the pandemic has changed the experience of people in ride hail. And so that's just one example. And so we really do note that and think about how that's important just outside our city.
So I'll take a local view, then pull it into a national view, because I think, but I agree with Nick that that transparency, as much as transparency can be done, is really critical in terms of usable data. So I think that, data sets that are downloadable, data sets that include, at least from the disease perspective, observations that may be helpful to others who are creating programmatic decisions, and also research is really important. So I think there's some great examples. I think that New York City has some great downloadable data sets for HIV and other diseases. I think that, again, looking at COVID, there are downloadable data sets with some limits, and then also things like giving a great example from CDC, COVID data tracker, which, if you haven't seen, is this amazing public portal where you can really look deep into data, and depending on how deep you want to dive, I think, for instance, COVIDnet, which is amazing, is a look at hospitalizations among people with COVID-19, and it goes down to the sites as well as race, ethnicity, age, et cetera, so you can really go deep, and people really do use that to make decisions and to sort of come up with plans. So I do also think that that another important element to data use is also really connectivity to the community of folks who use it, trying to get sort of a sense of what the limits are and being clear about the limits, but also identifying ways that we can push the envelope. I'll tell you that coming from a local jurisdiction to a national venue, for me, one of the frustrations is that every jurisdiction is a snowflake. And because of that, it is there's data coming from all directions. It comes in different ways, and appropriately, we don't have identifying information that comes into CDC, but are there strategies for data that would allow us to better be able to link data systems in a way to say more meaningful things without compromising people's privacy or even getting personally identifying information? So I think different than sort of on the jurisdiction where, the HIV registry in New York City, because of the way the registry works, has all of the identifiers that you need to be able to match HIV and the sexually transmitted infection database and even the COVID vaccine database. It all sort of interplays. But on the national level, it really depends on the ability of a local jurisdiction to do that work for us to be able to sort of say more global things. So I think that it sort of, to me, the notion of are there ways that we can push the envelope and use newer technologies where we're able to break silos of databases to be able to sort of see more without necessarily compromising people's privacy and security.
Yeah, and I'm so glad that you brought that up, because I think one of the questions that folks have is they're trying to address so many different issues around equity, right? Because equity is so very broad. And when you think about all of the available data, again, it is so very broad. So how do you create a framework where you can distill down the data that's needed to make the case for a program or to make a case for more funding? What's your approach there? What's the first step?
Do you want me to start this one, Nick? I'll go.
Yeah, why don't you go ahead?
So I think that the first step, and I'm going to use a tale of two infections as an example, since that's my world, is completeness of data. So I think that's like the first thing. So coming from that HIV space, most jurisdictions have mandatory HIV reporting. They have a very high level of reporting. The completeness for some of the race, ethnicity, and sexual orientation, gender identity stuff is pretty great in the HIV database. Like in some places, like over 90% complete. That's different than COVID. And so I think that the first step from my perspective is identifying ways to get more complete data in the areas that you're trying to address with equity. And I think that is like a key piece. So I can tell you that looking at CDC and COVID, like there's been a massive improvement in data completeness for certain elements. So for instance, like for vaccine, it's just jumped over time in terms of completeness. Like we're really getting good data on race, ethnicity. We're getting very little or nothing from the perspective of sexual orientation, gender identity, as an example, if that's an equity area that you're interested in. On the flip side, things like lab reporting for COVID, like notoriously has poor completeness because the labs don't necessarily report race or ethnicity, certainly don't report a lot of sexual orientation or gender identity, but their completeness for sex at birth is really high. And so, so that's an interesting sort of, piece of an observation, which is that your use of data has to start off with getting the most complete, and then really trying to identify sort of what the areas are that you'd like to address based on that completeness, and then really focus on like where you're seeing the gaps. But I think that beyond just identifying a number and say, oh, there's a gap here, it's also the next step, which is that data needs to connect back to the community that you're working with to make sure that you actually are interpreting it correctly and are identifying what the true gaps are rather than artifacts of data.
And I can add on to the local perspective on the framework question. And I think this brings a little bit of the legal side to it. When there are problems exposed, like Demetre was talking about, like the need with testing labs to collect data on race, age, gender, and how they've historically not always been great at that. At the local level, you turn to what are your tools? What are the levers that you have to pull in order to make action happen? Early on in the pandemic, our public health commissioner used the powers of a public health commissioner that any municipality has to issue a public order requiring labs that when they're submitting their data and when they're doing their tests, that they have to collect this information. And with the power of a municipality comes business licensing and permitting powers. And so there you have all these levers to be able to, you'll never get to perfect, but to be able to use whatever tools that you have. And when we did that, and we saw that on the data that was collected from labs that we were able to get race, ethnicity, sex, and gender information, and use that to early on identify that COVID, which was already suspected, but confirmed through the data that it was that different races and populations were experiencing the disease in totally different ways. That the rate that the Black population at the beginning of the pandemic was experiencing was much higher than other races. A few months later, it was the Latinx population. And Mayor Lightfoot was very early on. My memory is one of the first city mayors to release that data publicly and say, look, this is what's happening in the communities. And we have to use this information in order to react and respond and assemble teams in communities and let people know that the data is showing that they're affecting different areas of the city in very different ways. And I think it just comes back to the importance of that framework and the need to identify the levers that you've got at your disposal, and then to release and to make public and to let everybody know what it is that you're finding.
So thinking now back to standing up a program, understanding what you want to achieve from the program, What are some things that you've maybe run into as an obstacle that if you could go back and change, you would, that you think would result in better outcomes? I'll start with you, Nick.
Sure. So I've been working in government since 2006, and I time and time again, and I don't say this from a point of blame. I say it from a point of just reality that change management in an organization is it can never be understated. When you have, and again, I'm speaking from the perspective of a city, when you've got a large workforce that people have been in their jobs in varying amounts of time. Some people are newer and some people have been around for decades, and they've done the things that they've done in a very specific way for a very specific reason for a long time. Those reasons can be related to court orders. They can be related to, I mean, just think of the habits that are that we've developed as in our workplaces coming out of COVID and in the pandemic that we're going to carry with us for years. There's lots of these ingrained habits, culture around how we use data, and maybe we don't even identify it that way. The fact that something I might call data practice, it's not necessarily something that an agency or a group of people are even recognize as a data practice. And it's those differences of experiences and the culture of the workplace that I've learned over time cannot be ignored and have to be met with empathy, understanding, and real leadership of direction to say where we're going is that we understand how important data is. We understand how important collecting quality data from an equity standpoint is in order to setting baselines, making differences in the areas we're trying to make a difference. And we all have to do it together. And that's not something you can just say and expect that it's just going to happen, that an entire workforce is going to say, I'm with you, I understand exactly what you're saying. So it is a whole of government effort that is really just about culture building and changing habits and attitudes. And it involves everybody, including the people who are trying to make that happen. And so I talk about it as a challenge, but also as a learning and really a guide for moving forward.
From my perspective, I'm going to add a super public health sort of take on that, which I bet you isn't super public health, but also very similar to what Nick said, which is that beyond the people, I think that maintaining investment in the systems is something that is critical. And so when I think about the work that we've done and that I did in New York City with the Department of Health to sort of end the HIV epidemic in that jurisdiction, when I think back, what could have been done differently, I would say that I would have invested more in the systems for the data. And even if that meant putting a little bit less in the program, because ultimately those systems are critical. And frankly, as I think COVID has demonstrated very well, public health systems need some help from the perspective of what the actual systems look like. So though I don't call it a regret, I do think, and I think if you ask a lot of public health leaders, they'll probably say something similar if they've launched large programs that now in retrospect, saying that, if this much of the pie was meant to be for making sure that the data systems were able to support the work, maybe more of that piece of the pie should have gone in that direction. And I think that we're able to sort of change that story prospectively. So I think we need to think about things like tuberculosis. And so TB famously has what they call the U-shaped curve of concern, which is when TB is really, really high, all of a sudden TB systems have a lot of funding. And as soon as TB goes low, the TB systems lose their funding, and then TB goes up again, because that's just what it does when you're not able to sort of manage the system. And so I think though COVID is going to be different, I think that HIV is really a great example of that as well, which is that I think that vigilance to being able to measure what you're doing and have outcomes that are truly quality and measurable, and that being critical in and support the programs to move forward, and then yield in effect more support to more programs. So I would say that's my one thing that I would change in the past, and definitely thing I'm changing in the future.
So what I heard from that is set up the system, take more time to ensure that there's investment there, and don't take the foot off the gas. Keep that investment going, otherwise can fall behind. Which I think is a really important point when we're thinking about investment, because I think folks talk about equity and it's something that folks want to accomplish, but thinking about the investment that's truly needed to get there is something that takes learning. How do you have those conversations about learning? What's the elevator pitch to colleagues, to others, to say, this is why we need to invest in data specifically for equity?
Well, in our organization, it's really started in the mayor's office with having data as a function and equity as a function, both existing in the same place, tied directly to the executive. And so then from there, we've got a chief equity officer, we have a chief data officer, and our offices work together, hand in glove on everything. And so that's been one first step to making sure that that equity is at the forefront of when we think about data practices. And then once you build out then from that foundation, there is the equity team takes measures to work with all the departments and to create surveys to understand current practices, create goals, and work with department leaders to set where the direction is going in the future, and then work with policy to embed into permanent city policies and operations that these are the North Stars, these are the ways that we measure them. And so it's kind of that, I think that ties in that systemic change management part of the conversation, but that's how we've treated it as an organization.
So I think from the CDC perspective, and also from the New York City perspective, I've lived similar experiences, and actually is identical to Nick, which is that leadership has to sort of say, this is a priority, and then align the systems to be able to make it a priority. So in New York City, I had the great pleasure of working with Mary Bassett, who is an equity leader across the country, now going to be the Commissioner of Health in New York State after a little twirl at Harvard. She's amazing, and she made it a priority. And so really having sort of equity eyes that interact with data is critical. Same at CDC with Dr. Walensky, and really the commitment from the administration, putting health equity front and center. Really the guiding principle is pretty much what Nick said, which is that we're baking in equity to all of the work, both programmatic and data. And that sort of baked inness is what allows it to move forward sort of in a way that is both scientific and also responsive to the equity needs to achieve bigger health equity goals.
And this question may be a little controversial, but let's go there. Sometimes it seems as though when we're talking about equity, there are different groups that want different things, and sometimes they don't always align, or there could be competition for resources. So hearing you talk about having kind of the support from the top and making sure that everyone is involved, there can still be a little bit of headbutting. How do you deal with that?
I'm just gonna. It's a recurring theme in this conversation. I'll acknowledge that, but I'm going to come back to transparency because when I'm thinking to indexes specifically. Your question made me think of how often there's a practice to take like a lot of different factors and metrics. It might include race, it might include income, it might include gender, and have a lot of different factors that involve a lot of groups of people who where historically there's been inequities, and then kind of boil it down into an index. And that's a space where oftentimes I see the controversy arise because there's questions about how did you calculate it, how did you weight different factors, and what I've seen, if there is going to be an index that documenting exactly how things were done, showing exactly how things were calculated, and being fully open and public with this was what led to the thought to put this in here this way. This is how it was done. Have at it, evaluate it, debate it. Let's talk about it. It is the best way to move forward. So I would say just being transparent about however you're doing things, however you're thinking about things. If you've identified an inequity and you want to work against that inequity, show how you're doing it, explain where you got it from, and maybe you'll learn that you missed a group or you missed a way to calculate it. So it's all about transparency.
So I'm going to just ditto Nick. 100% transparency. And I also think, just to sort of add to like answer your question, your controversial question controversially, it also requires some bravery in being okay with talking about those issues transparently. So I think that's so it's not just a transparency in process, but the ability to say, like, we're having there's a conflict. And so really sort of saying, like, we're going to have to address the conflict and come up with a solution. And I think that's sort of what happens when in the sort of leadership perspective, you're given the charge to sort of address health equity in a way that is different than you've done before. And so I think that those conversations, though difficult, are ones that are critical and also require that you have a staff that is also sort of diverse in their own experience to be able to really delve deeper.
Okay, so we went from controversy, let's go to hope. Let's end on a really positive note here, gentlemen. Final question. What gives you hope about the growth of data in the equity movement? I'll start with you, Nick.
What gives me hope is how much has happened in such a short amount of time over the last few years. I come back to the pandemic and the speed, the passion, and just everything that was brought from all over in order to get to this data, to understand how it was affecting different populations and just communicate it publicly, created a new standard for how to do this kind of work. And we've extended that same concept now a lot since then. We've taken the concept and said, we'll do the same with our employees. We collect all the demographic information about employees, and we post it in aggregate on our website, update it every night. We do the same thing with people who are in the criminal justice system, arrested, or even victims of crimes. Race, age, gender, as much as we can get, and regularly update and publicly post it. And so I'm just so excited about how this has become a norm, and how we can continue to move in this direction, and just how much we're doing now all of a sudden, and it makes me hopeful for going forward.
So I agree. I think that that in some ways, sort of living in sort of that HIV space that I live, where we have really complete data, like, this is the thing that we've sort of been hoping for. That there's an acceleration, and that it is something that's put at a premium, sort of getting better data to be able to sort of create better programs to address racial inequities and other inequities that exist in the system. So I'm really excited that this is a priority. And so when I go on a call and someone says, "What do you mean that we don't have that data?" I love that that's the question now, because the expectation is becoming that we do have it. And so I think that's powerful, and I hope something that will stick with us beyond the pandemic.
Wonderful. Well, I realize that we are at the end of time here. We do have a couple questions, so I want to just do a quick time check. Do both of you have 2 more minutes?
I don't. I'm actually getting called to another meeting. I'm really sorry.
Okay. Well, thank you both for your time. This has been absolutely wonderful. I appreciate your expertise.
I apologize. It's the limiting factor. Have a good day. Thank you for having us.
Thank you so much for having us.